Hello, this is Tony DeMaria, the editor of the Journal of the American College of Cardiology, and I'm here with another issue of the Genuine article. Again, this format is one in which I present to you some of the findings of really interesting papers that are or are about to be published in JACC. And this morning, the topic I'd like to talk about, I guess, is a little bit relevant in terms of the recent death of Tim Russert. His death, again, emphasized the inadequacy of our current screening techniques for coronary artery disease. As I understand it, he's a man who sought medical attention, had stress testing, and in fact was under therapy for both high blood pressure and for high cholesterol. Nevertheless, he had an acute myocardial infarction. And we know acute coronary syndromes actually present in about 50% of patients who have been totally asymptomatic prior to that. So the question that has been on a lot of minds for the past several years is, what can we do to improve our screening for coronary artery disease to enable us to prevent these events? And in that regard, there's been a number of suggestions, primarily involving imaging. Can we image atherosclerosis in other vascular beds? Because that really should be the very biggest risk factor for atherosclerosis in the coronary beds. And in that regard, people have talked about carotid intimal medial thickness screening, coronary calcification. And in a forthcoming issue of JACC, we have a fascinating paper about using coronary tomography angiography for screening for coronary disease. And of course, one might speculate that detecting coronary stenoses by angiography would be, in fact, the very best screening technique. And the question has been, if one applied this to an asymptomatic, ostensibly healthy population, what would one find? And in that regard, this manuscript that we published comes from Korea. Doctors Choi and Choi, actually two first authors, report on 1,000 patients who were self-referred on a voluntary basis to have coronary tomography angiography as part of a routine health evaluation. And so 1,000 patients, asymptomatic, otherwise healthy, really represent a wonderful patient population to study. All of these patients underwent CTA. They were about 50 years old, the mean age, a slight majority males, but a relatively young population. Now, there were two observations that were attempted to be made in this study. One was, what was the yield of coronary disease from coronary computed tomography angiography? And secondly, how did it compare with conventional risk stratification, such as by the Framingham score? And in terms of the first question, in fact, CTA identified lesions in 22% of the patients screened. Now, in about 4% of the patients screened, the lesions were non-calcified. So it was only the angiography that would have revealed these lesions. The remaining 18% of lesions were calcified and could have been detected just by calcium screening. There were a number of other interesting facets. It turns out that about 25% of the lesions that were detected would have been called significant or severe, so that they were more than minor lesions. Again, the bulk of these, but not all, were calcified and presumably would have been detected by coronary calcification screening. Now, importantly, about a quarter of the patients who had significant lesions, in fact, would not have been classified as high risk by the standard Framingham score. So that they demonstrated that using CTA with coronary calcification screening identified patients that would have been assigned to relatively lower risk strata had we used the conventional approach. Now, in terms of the benefit of this, one can question what good comes of it. Well, of course, the more intensive risk modification management that would be applied would be one benefit. Here in this case, 10 of the patients, 10 of the 1,000, so about 1 in 100, underwent revascularization. Now, we don't have the long-term results, but presumably these patients would have been benefited. That remains to be seen. What we do know is that over a period follow-up of about a year and a half, approximately 15 coronary events happened. All events happened in patients who had CTA, which were abnormal, who had abnormal CTAs. There were no events that occurred in patients who had normal CTA. So looking at this study, I think it's really fascinating. These are first data on CTA screening of a very large asymptomatic, otherwise generally healthy population. It shows that, in fact, there are a significant number of patients who show some evidence of coronary artery disease, and a not inconsequential percent of them would not have been identified as high risk initially, and in fact, some of them seem to be good candidates for intervention. Now, obviously, CTA has its downside. These patients received an average radiation exposure of about 13 millisieverts, and we know that that's got a carcinogenic potential. They got a contrast load, and it's conceivable that anxiety was provoked in some of these patients who, in fact, will never have a coronary event. We also have to recognize that this is a uniform population of Koreans and may not apply to other individuals. The take-home messages, I think, that we have to again recognize that our conventional risk stratification modes are not perfect, that they have limitations. We need to continue to look for better risk stratification modes. I think that what we have is some evidence that if we can get the radiation dose of CTA down, if we can get the contrast load of CTA down, that in fact it has some intriguing possibilities as a screening technique in the future. For the Genuine article, thanks for viewing. I'm Tony DeMaria.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.